Webinar covers the specialized system within the heart called the cardiac conduction system. This specialized system is capable of generating electrical impulses in a regular manner that's capable of, or I should say intended to create contraction of the myocardium. Plus, this system allows these impulses to be conducted very rapidly through the heart. The idea behind it is in order for the heart to act as an effective pump, the muscle cells need to work as a unit, and so this specialized system will allow it to work as a unit so it can create the pressures needed to be able to pump blood. Plus, the heart is able, with this specialized system of cells, to initiate the electrical activity. So it does not need external stimuli. So we have these electrical cells, which we'll be talking about in the webinar today. We've already discussed the mechanical cells, which make up obviously the bulk of the heart, which are responsible for contraction and generating the tensions needed to create pressures to move blood. We're going to talk about, for this short webinar, is to discuss the electrical cells that initiate the electrical activity, as well as conduction of the electrical impulses through the heart. Now, the cells have the ability of being able to automatically generate their own action potentials, and we call it automaticity. This is unlike skeletal muscle. So they can generate their own action potentials without external stimulation, such as the nervous system, although the autonomic nervous system can modulate the activity of the heart, but it can create its own action potentials without the nervous system. These cells also have the specialized characteristic of rhythmicity, which means when it does generate those action potentials, it's in a regular, repetitive manner. The significance of having this rhythmicity is that if you have an abnormal sequence of contraction of the heart chambers, you're going to diminish the pumping effectiveness. And so having this rhythmicity allows it to work as a unit, allow the atria to fill up the ventricles, then the ventricles work as a unit to pump that blood out. Keep in mind that if you have any damage to these specialized systems in the heart, you will have an abnormal sequence of contraction of the heart chambers and diminished pumping effectiveness of the heart. Now remember from previous lectures that the myocardial cells are connected by these structures right here, which you see where the arrow is, plus I'm also indicating some others, to remember what these specialized structures are in the heart. Well, they're intercalated discs. The intercalated discs are gap junctions as well as desmosomes. The desmosomes helps to kind of connect the cells together, but the gap junctions allow the cells to transmit the electrical potentials very quickly throughout the heart. Now the way the system is set up is you're going to initiate the electrical stimulus in the SA node, which we're going to be discussing shortly, but then the information is going to be sent out through the atria. So the atria will be the first to contract after it's depolarized, followed by the ventricles contracting. And remember, when the ventricles contract, they contract from apex up to base. And how the system, these specialized cells, are arranged allows this to happen. So we're going to look at this picture, and I will discuss each component as I go down through this picture. We're going to start off with the sinus node, which is also called the sinoatrial node, as well as the SA node. So it has more than one name. This is the normal location where the electrical impulses originate. So we call it the pacemaker of the heart. So we're going to discuss this first and how or why it's able to spontaneously generate electrical impulses. As well, then we'll talk about how it's conducted through the rest of the heart. So let's look at the SA node first. The cells in the SA node are called P cells, short for pacemaker cells. These cells are were derived from muscle tissue, but they have kind of evolved where they eventually really have very few myofibrils. So these cells do not contract. It's very important that you realize if I talk about the cardiac conduction system and the cells that comprise it, they are not contractile. They're only electrical cells. They either spontaneously generate electrical impulses or they transmit the electrical impulses within the heart. They do not contribute to contraction of the heart. Now, these cells are located in the upper lateral wall of the right atrium. They exhibit what we call automaticity. So if you look at this picture here, earlier lecture, you learned about the fast action potentials in cardiac muscle cells as well as the slow action potentials in the nodal cells. So this is what we're discussing today. Look at the action potentials. They're different. There's some major differences between the two action potentials. So first thing to realize with the SA nodal cells is their cells are notoriously leakier to sodium. So what you'll notice here, there is no true resting potential. They call it actually a pacemaker potential. So it never really sits down like you see over here in the cardiac muscle cells. It kind of slowly depolarizes because those cells are leakier to sodium. So and you'll notice that the resting membrane potential is less negative as in cardiac muscle cells. And the reason why it's less negative is that slow influx of sodium into the cells negates some of that negative charge. So the cells, or that membrane potential, is closer to threshold. So these cells are leakier to sodium, and sodium kind of is leaking in. Remember, it's also through these funny channels, and this term right here refers to funny current. The reason why they call it the funny cells or funny channels is they realized that the sodium influx into the SA nodal cells was not blocked by tritatodoxin, which is a toxin found from pufferfish. It would stop the cardiac muscle cells from depolarizing, but did not have an effect upon SA nodal cells because these are different types of channels. So sodium is coming in. When it reaches threshold potential, which is about minus 40 millivolts, you get this big influx of calcium. So this upstroke, or this phase 0 in SA nodal cells, is due to calcium influx, unlike what you see in cardiac muscle cells. Here was due to sodium influx. Here's the reason. At this membrane potential, the voltage-gated sodium channels are already inactivated. They're turned off. You can't open them up. And so this depolarization that you see here during phase 0 is due to calcium influx. You'll notice there is no phase 1 or phase 2 in SA nodal cells. The phase 3 is the repolarization, and just like you see in the cardiac muscle cells, it's due to potassium moving out. Once it reaches its resting potential, again, I'm using air quotes, that it will just all of a sudden start to depolarize again because of those leakier sodium channels. So when you look at the SA nodal cells, because they're notoriously leakier to sodium, they have the tendency for self-excitation. The sodium comes in and it reaches a certain threshold potential. The voltage-gated calcium channels are going to be open, and you're going to get this depolarization of the cells. So because of the differences in the ion channels in SA nodal cells versus the cardiac muscle cells, they exhibit automaticity. Once these guys, SA nodal cells, fire, what they're going to do is they're going to send the action potentials out through parts of the conduction system as well as adjacent muscle cells. So this slide again is just kind of showing you what I showed earlier, that the automaticity of the SA nodal cells is because that they're leakier to sodium. That membrane potential is closer to threshold, so it will spontaneously depolarize, and it's because, again, the ion channels are somewhat different in the SA nodal cells. So it fires, it creates this action potential. It's going to allow adjacent muscle cells to depolarize, as well as other cells that are electrical cells that are going to allow me to transmit the electrical impulse pretty quickly. So when you look here, when I want to get that electrical impulse throughout all the atria and eventually to the ventricles. So one of the things I'll do is these internodal pathways. Internodal pathways means between nodes. So I need to go from SA node down here to the AV node, which is still in the right atria, but eventually we're going to go into the ventricles. So internodal pathways are going to conduct the electrical impulse to the AV node, transmit the electrical impulse a meter per second versus 0.3 meters per second that you see in atrial muscle, which allows it to conduct very quickly. Simultaneously, you have these interatrial bands that allows the electrical impulse to go from right to the left atria, so we can get eventually the left atria to depolarize and contract. But pretty much what's going to happen, it does go pretty quickly, that the atria, both atria, are going to contract pretty much simultaneously. But what's going to happen is I have that electrical impulse making its way to the AV node. I need that impulse to go into the ventricles because I want the ventricles to contract and pump blood up to the lungs or to the rest of the body. But what happens at the AV node is the AV node, the cells, the fibers are in there are a little bit different. They don't have as many gap junctions. The fibers aren't as big, and so the conduction of the electrical impulse slows down considerably. If you look at any part of the cardiac conduction system or even compare it to muscle, the conduction of the electrical impulse is the slowest through the AV node. But it's very important that this happens. Now this AV node is still in the right atria, kind of around where the coronary sinus would be, the opening of the coronary sinus. The slowing of that impulse is going to allow the atria to finish up pumping the blood into the ventricles so the ventricles can fill. If it didn't slow it down, you might have the atria and the ventricles contracting simultaneously, which isn't very efficient. So you want the atria to finish up topping off the ventricles, and then the ventricles to contract. Plus, remember that between the atria and the ventricles, you have that connective tissue called the annulus fibrosus, which stops any electrical activity from going from the atria down to the ventricles. This is the only way you're eventually going to get that electrical impulse down to the ventricles. It's got to go AV node down through what we call the AV bundle before you can get into the ventricles. So the electrical impulse makes its way to the AV node. Anything that was here dies off because that connective tissue, that annulus fibrosus, physically acts as an electrical insulator. The electrical activity is going to die off. So you don't get the ventricles depolarizing from top to bottom because you don't want that. You want the ventricles to depolarize bottom to top because that's the order in which you want the ventricles to contract, because the blood needs to come up this way where the openings of the aorta and the pulmonary trunk are. So what happens is you get that slowing, finish up topping off the ventricles. Then the electrical impulse is going to physically go down across that annulus fibrosus through the AV bundle. The AV bundle, let's go back here. AV bundle is also called the bundle of His or the common bundle. It has more than one name. This is the only normal way that the electrical impulse will go from the atria down to the ventricles. So this is where the Purkinje fibers start to originate. Okay, so they begin to start to originate here. Once they get through here, you have what we call the bundle branches. You have a right bundle branch right here. You have a left bundle branch. The bundle branches are bundles of Purkinje fibers. They're found very close to the endocardium, down through on the septum. The right bundle branches are going to allow the electrical impulse to get to the right ventricle. The left bundle branch is going to allow the electrical impulse to get to the left ventricle. Well, those bundles of Purkinje fibers are very large. Those fibers are extremely large. They're going to conduct the electrical impulse the quickest of anything when you compare it in the heart. Any part of the cardiac conduction system or comparing it to muscle, atrioventricular muscle, it's by far the fastest. It can go up to 4 meters a second, which is going to be significant. So if the ventricles, which are bigger than the atria, will actually depolarize faster than the atria because of those Purkinje fibers. So over here it says to get to most of the ventricles, it's only 0.03 seconds. That's pretty fast. So what you'll have is the bundle branches will eventually terminate into what we call terminal Purkinje fibers, which only go into the endocardium about maybe just about a third of the way through into the myocardium, sorry. But that they terminate, but when they depolarize, they're going to allow the muscle, adjacent muscle, to depolarize. So the Purkinje system allows us to conduct the electrical activity throughout the ventricles fairly quickly. So we can get the right and left ventricles to conduct together, which is going to be very important to be able to create enough tension, enough pressure so we can move blood. When we look at this picture, which you have in your notes, we're going to compare or show you how quick all this happens. And these numbers refer to the fact that if you have at the SA node, it's time 0, the electrical impulse is initiated here. These other times tell you how much time has elapsed from the point where it initiated in the SA node till it reached that particular area in the heart. So if you notice, start in the SA node. Most of the atria, or I should say all of the atria, are depolarized within 0.09 seconds, which is 90 milliseconds. Okay, not bad. You'll notice that the left atria is a little bit longer than the right atria because we had to go all the way over to the left side. But still, it's enough time that these guys will contract somewhat at the same time so they can work as a unit to top off the ventricles. It only took 30 milliseconds to go from the SA node down to the AV node. But what you'll notice here, from the AV node down into the ventricles, there has been a 130 millisecond delay that's taken place. This is showing you that significant delay that takes place in the AV node. So 130 milliseconds just to go from this point down to the ventricles. But remember, we wanted that to happen. Then if you start looking in the ventricles, to get all the ventricles depolarized, if you compare this number versus here, the difference is about, if I do the math in my head really quickly, 60 milliseconds. So it takes about 60 milliseconds for all of the ventricles to depolarize. Okay? That's quicker than the atria. So tell me why the ventricles, which are far bigger than the atria, why do they depolarize faster than the atria? It's because of those Purkinje fibers. The Purkinje fibers transmit the electrical impulse the quickest. Now what could happen though if SA node decides not to fire? We can have alternate pacemakers. So we have these P cells in the SA node. You do also have P cells in the AV node. And they're not P cells in the Purkinje cells, but the Purkinje cells also, or I should say Purkinje fibers, they have the ability of automaticity. So why does the SA node is the normal pacemaker? It depolarizes the fastest, faster than the spontaneous depolarization rate of the AV node or the Purkinje fibers. Now, what would happen is, or what normally happens is when the SA node fires, by the time the AV node would spontaneously fire, the SA node has already depolarized it. So it's pretty much the fastest wins. So as long as everything's fine, the SA node is going to be responsible for creation of that regular, repetitive rate that you get in the heart. In the SA node, the spontaneous depolarization rate would correspond to a heart rate of 60 to 100 beats per minute. There's variations there, and that incorporates the variations in the population. So SA node normally fires between 60 and 100 times a minute. Well, the AV node doesn't depolarize as quick as that. It depolarizes anywhere from maybe 40 to 60 times a minute. The Purkinje fibers, they're only maybe, they can be as low as 20, but anywhere from like 20 to 40 times a minute, and they're not very reliable. So when would these guys become a new pacemaker? Well, if the SA node decides not to fire, or you have some sort of block in conduction from the SA node to the AV node, the AV node will spontaneously fire at its rate of anywhere from 40 to 60 times per minute. Why would you want that to happen? Well, if that electrical impulse doesn't make its way to the ventricles will not be able to depolarize, will not be able to contract, and you're not going to pump blood. So we need to make sure electrical impulse makes its way into the ventricles. So SA node, we'll say the SA node did fire, but there's a block somewhere between the SA node and AV node. Atria is going to depolarize. They're going to contract anywhere from 60 to 100 times per minute. But because that electrical impulse didn't make its way to the AV node is going to fire, and fire between 40 and 60 times a minute, and that will set how fast the ventricles contract. So what you would have is you'd have two rhythms. The atria are beating at a certain rate, the ventricles beating at a certain rate, which is not very effective, not very efficient. And we're going to talk about that in class when that happens. Well, also what may happen is if there's a block or problem with the AV node, or maybe the AV node can fire, but there's a block somewhere below, and it can't make its way into the ventricles. So again, ventricles need to depolarize so they contract and pump blood. So the Purkinje fibers can spontaneously depolarize, but it's a much, much lower rate. And it would correspond to a heart rate, or I should say ventricular rate of anywhere from 20 to 40 beats per minute, which is not very good in the long run. 20 beats per minute, most people, you'd pretty much be in bed, not be able to do much of anything. You'd be in the hospital. So you would not be able to get an effective cardiac output with very low heart rates. So, but this sometimes happens, and we'll discuss this in class. When these happen, if you have an alternate pacemaker that's set up in the heart, they call it an escape rhythm. So the reason why they call it an escape rhythm is you've escaped from the dominance of the SA node, because the SA node is dominant. It kind of normally creates that normal rate and rhythmicity in the heart. But if something happens where we have to set up another pacemaker, they refer to it as an escape rhythm. So this is the end of the discussion on the cardiac conduction system. But what we're going to do next is we're going to discuss the normal ECG, what the ECG will tell us, and that will be showing you the electrical activity that is associated with the heart and what information you could get from an ECG, and what the normal things that you need to see. If you understand what you normally see on an ECG, it'll make much more sense of what you would expect if there's something wrong, say, with the cardiac conduction system, or if there's some sort of damage to the myocardium. So that will be the next webinar.